Today we'll be talking about Patellofemoral Pain Syndrome, also known as PFPS. And essentially what this is pain around the knee or behind the kneecap. You might also hear it referred to as simply anterior knee pain, as PFPS is kind of a catch-all term in many cases for pain to the front of the knee.
Hey everyone, this is the Pragmatic PT, and as always, this video reflects my personal opinion based on my own interpretation of the literature. This video is intended to be a source of information and not medical advice. If you are currently dealing with an injury, I highly suggest you seek help from a qualified medical professional.
Common in all populations, with it impacting up to 29% of adolescents, 23% of adults, and up to 36% of cyclists. This can be a chronic condition, with it lasting for years and around 50% of people who suffer from it. So this is something that we should be paying attention to and trying to solve. Activities that are commonly painful when suffering from this syndrome are things such as ascending and descending stairs, running, or squatting. So as you can imagine, this sort of syndrome and pain can impact people's daily life as well as their recreational activities, and can really impact people's ability to stay active and healthy. Now that we've taken a look at what patellofemoral pain syndrome is, how many people it impacts, and what sorts of activities it will likely impact you with, let's look at some of the risk factors for PFPS. Well, previously in research, a few of the risk factors that were identified for PFPS were things such as low knee extension strength, increased navicular drop, and greater hip adduction during running. Now, a little bit more about these each individually. The low knee extension strength is essentially a reduction in strength with knee extension, just like you would experience on a knee extension machine at the gym. So essentially, how much force can you produce when trying to straighten your knee out in the image that I'm showing here? The increased navicular drop is exactly what it sounds like. An increase in drop of that navicular bone kind of on that mid-arch of your foot. So basically flattening that arch out. And then greater hip adduction during running. And this basically is when you run, is your knee kind of caving into the inside. Now, what's interesting is that the increased navicular drop and hip adduction kind of go hand in hand to some degree, because as the navicular drops down, the arch of your foot is being flattened. That tends to have an effect of your knee coming to the inside, which also increases what we would consider hip internal rotation. Okay, so we've looked at previous risk factors. Now let's take a look at some of the more current risk factor findings in more current research. So one thing that is held pretty constant is the idea of lower quadriceps strength being a risk factor for PFPS. Now, counter to previous evidence, current study found that a higher isometric hip abduction strength in adolescents was a risk factor for developing PFPS. So, like I said, that runs counter to previous findings of the greater hip adduction during running. We tend to associate greater levels of hip adduction during running as being a reduction in your abduction strength, so your body's ability to maintain the hip being slightly abducted and avoiding that knee caving into the inside sort of position that was previously thought as a risk factor. Now, the authors of the study do speculate on why this might be for adolescent individuals, and essentially what they're stating is that in adolescence, those who are competing more frequently or maybe competing at a higher level would likely be stronger, but those levels of activity would increase their risk for something like PFPS. So don't take away from this that stronger hips lead you to PFPS, because we essentially know that that is not true, as doing hip strengthening and things of that nature tend to actually help with this sort of pain. And that is as good of a segue into treatment for this disorder as anything else, I suppose. And essentially, for the most recent consensus statement on PFPS and its treatment, here's a list of 6 things that they either recommend or don't recommend for the treatment of PFPS. And the first one is exercise therapy. So essentially, they're saying exercise therapy has shown to be effective in both the short, medium, and long terms as far as improving function and reducing pain. And they do recommend a combination of hip and knee strengthening exercise to achieve these outcomes. Both have been shown to be effective. If you do hip strengthening alone, it's shown to be effective. If you do knee strengthening, specifically quadricep strengthening, that has also been shown to be effective. So a combination of both, it seems to be a good overall approach for the improvement on pain and function with PFPS. They do also state that the inclusion of something such as foot orthotics, patellar taping, or manual therapies can be effective in reducing pain, at least in the short and medium terms, and also state specifically that foot orthoses or orthotics are recommended to reduce pain in the short term. They make a specific point in stating that lumbar mobilizations or manipulations are not recommended if they're done alone. So essentially, going to your physical therapist or your chiropractor, having them do a quote-unquote adjustment to your lumbar spine is not recommended in isolation without other treatment modalities such as exercise. They also state that patellofemoral mobilizations, such as moving the kneecap side to side or up and down, is not recommended in isolation, as it has not been shown to be effective. And the last point that they make in that study is that electrophysical agents are not recommended for the treatment of PFPS. So those are things such as electrical stimulation, ultrasound, superficial heat, and several others. So that is the current state of PFPS research, how many people it impacts, what sorts of activities people are impacted with, our understanding of risk factors both in the past and currently, and what the best recommendations are currently for the treatment of PFPS.